Good afternoon. I'm Dr. Michael Krychman. I'm one of the associate editors for The Female Patient, and I'm very excited today because we will be talking about updates in vulvar-vaginal treatment. Today I'm joined by Dr. Jim Simon. He is the clinical professor at George Washington University. He's also the president and medical director of Women's Health and Research Consultants. He is also on the board of ISWISH, the International Society for the Study of Women's Sexual Health. Good afternoon, Dr. Simon, and thank you again for joining us today.
Good afternoon,
Jim,
Michael. Thanks for being here.
let's just jump in right now, and if you could just update me a little bit. I know there's a lot going on in terms of research and publications and new medications in terms of vulvovaginal atrophy, and it's really an exciting time to be studying this as a menopausal specialist. I'm wondering if you could update me a little bit about what's been going on in terms of different medications, and let's maybe start off with DHEA intravaginal suppositories.
Well, I think the big issue is that since the WHI came out 10 years ago, the focus has been on non-systemic therapy of vulvovaginal atrophy. And the concept between systemic and local is a little bit blurry sometimes. We'll talk about that a little later. But the idea behind DHEA suppositories or dehydroepiandrosterone suppositories is that they're taken up, the compound is taken up into the vaginal cells themselves, and the cells convert them into both testosterone and estradiol. The estradiol makes the vagina estrogenized, and the testosterone improves the muscular function of the vagina. And the idea is everything's much better than it used to be, and at the same time, that's all intracellular with little or no systemic absorption of those active ingredients.
That's really exciting. And I know that it's in stage 3 clinical trial, so not yet commercially available. Do you have any update in terms of when this trial will be completed, or we really just need to stay tuned?
Well, I think we need to be patient, and even if the trial is completed relatively soon, that doesn't mean it'll be available anytime soon. We have to wait for the FDA to pass judgment. But it's a very exciting idea that you can put an active hormone in the vagina, one that is then converted to hormones necessary for vaginal health, but not have those active hormones absorbed into the systemic circulation for women like those with breast cancer, for example.
Right, and that's a really huge group of women who are really suffering in silence. And what I found very exciting about the DHEA and the studies is I think there was actually even one study that looked at lowered sexual interest, or HSDD, and these intravaginal suppositories. So it will be a very exciting time to hear that data and see it finalized. What about the other medication, the brand name Ospina? You know, they're going to be going for first in class an oral medication to treat a local problem. So I'm wondering what your opinion is and what you think about this, and again, staying tuned for further results and data, but kind of update the viewer in terms of what your thought process is about this.
Yeah. Ofina, which may turn out not to be the official name, is one of the potential brand names for a SERM, or estrogen agonist antagonist, called ospemifene. Ospemifene. And ospemifene, like other SERMs, has estrogenic actions in some tissues and anti-estrogenic actions in other tissues. And this particular one is being developed because it's highly estrogenic in the vagina with little or no activity in the endometrium. The company Shionogi that's developing the product recognizes that many women don't like to put creams or tablets or rings in their vaginas, and that's a barrier to use of anything, and in fact, sometimes a barrier to sexual contact for their partners. And so this is a pill, and we in the US use a pill for just about everything. This is a pill that is being developed for its treatment of vulvovaginal atrophy.
Yeah, and as gynecologists, we really can relate to that. If we look back recently, there's really been a shift from oral medication to treat yeast infection for local treatment, and really, patient preference is certainly an important issue. You talk about creams and intravaginal application, and I know there's been new data on low dose creams as well as low dose estradiol tablets. What's your thought about these products and where will they fit in terms of the marketplace?
Well, the FDA is focused on companies finding the lowest effective dose. It's almost a mantra up at the FDA. So Novo Nordisk, the makers of Vagifem, have marketed the 25 microgram vaginal tablets for a long time, and they were asked to actually find the lowest effective dose, which looks like it's 10 micrograms. The advantage of the 10 microgram tablet is that even a year's worth of Vagifem only amounts to a little over 1 milligram of total estrogen delivered. And so it's likely that it's safe even in breast cancer patients, although obviously it's not FDA approved for use in breast cancer patients. So it's extremely low dose. The efficacy seems to be similar to, if not identical to, the higher dose, and seems to work extremely well even at these extraordinarily low doses. It has the advantage of not being messy. It has the slight disadvantages that it's a little less effective for the vulva than it is for the vagina, which is why there seems to be a persistent place for low-dose vaginal creams, which can be applied both intravaginally and on the vulva directly.
Right. And, I'm a very big proponent of vulvar care, and I think that's a very important issue that even though women will have relief of intravaginal dryness, they still have complaints of, pain on insertion or still persistent pain during sex. And not only the vulva, but also the clitoris remains sensitive to it. Dr. Simon, you really make a very good point, and especially about the discussion about breast cancer patients. And, I see many of these women, and they are suffering in silence. And I think it's important to also mention that there are a lot of companies that are dedicated to innovative treatments without rise in systemic levels. We're also seeing small studies in intravaginal testosterone being used in breast cancer patients, and even companies are exploring intravaginal tamoxifen for the treatment of vulvovaginal atrophy. So this patient population is certainly very, very desperate for safe, effective treatments, and they are really suffering in silence. But getting back to another issue, you had talked about the introitus, and very important aspect in terms of treatment. I'm wondering if you could elaborate on that aspect for us a little bit.
Sure, the introitus is commonly overlooked as a focus for treatment. This is particularly an issue in patients who have insertional dyspareunia that they suffer through and then can have penetrative intercourse once they get past the introitus, so to speak. I think we often forget that nulliparous women in particular may have a loss of elasticity at the introitus or a constriction of the introitus to about 50% of its normal size, which makes it very difficult to have painless sex. Those women commonly need direct application of either estrogen topically to the introitus or estrogen and testosterone topically to the introitus, and may, in addition, need physical therapy and self-dilation beyond just an occasional act of intercourse. This turns out to be really important in our older couples who have intercourse less frequently and where intermittent dilation may be required to maintain a patent introitus.
Right, and I think that's very important to kind of mention genital pelvic floor therapy in addition to dilators, and that really remains an integral part of the overall comprehensive treatment. I want to thank Dr. Simon very much for attending today and really giving us some updates and insight to the treatment of vulvovaginal atrophy. And I know it's really an exciting time. There's a lot of things going on in terms of oral medications, even intravaginal suppositories, and really about addressing the breast cancer patient population. I think we would also be remiss if we didn't talk about the non-hormonal issues, including moisturizers and lubricants, and that probably will be a topic for another webcast because I know those are really frontline and very important. And even many people don't even know the difference between a moisturizer and a lubricant. So I would thank Dr. Simon again for his time and really insightful comments for treating vulvovaginal atrophy. And thank you all for attending the updates in treatment for vulvovaginal atrophy. Thank you again, and we'll see you again soon. Thank you.